Well, thank you very much. So I'd like to start. Thank you all for being here. And my apologies for being late and technically unsound. So with this, I'll start with sort of the twin epidemics in the midst of this pandemic of diabetes and old age. And as you all know, the diabetes has increased dramatically over the years to perhaps up to 33% of some states and counties based on the CDC data. Also, the population of older people has increased, and one estimate estimates that 22% of the population will be of an older age, greater than 65, in 2050, compared to 8% of such population in 1950. So we are in for some problems if these two groups coalesce. Some of the things to think about in diabetes in older adults includes the epidemiology, pathophysiology, how do we prevent it, and how do we treat it. And then at the bottom, I have a large number of considerations that we should keep in mind for the elderly, which I think are very much the bailiwick of psychiatry, but really should be the bailiwick of all of us, such as neurocognitive function, depression, hypoglycemia, and other and social support systems. So the prevalence of diabetes by age in older people is significantly higher. This is NHANES data compared to people who were younger than the age of 60, 40 to 49, and 50 to 59. About 20% of older age adults have diabetes. This includes 12% of prior diabetes, a smaller percent of people diagnosed by fasting plasma glucose, and new diagnoses also by an oral glucose tolerance test, which we don't do very often because it's inconvenient. But nevertheless, it tells us that a large number of people actually have diabetes, diagnosed or undiagnosed. About 34.2 million people of all ages, or 10.5%, have diabetes in this country. And if you go down a bit, about 7.3 million adults are unaware of their diabetes. Finally, again, as I mentioned before, 26.8% of those who are over 65 do have diabetes. A little more drilling down shows you the over 65s, the 26.8% in total on the far right side. Can you see a pointer on your screen? Mm-hmm. Yes, okay. And this is significantly higher than the total percent of diabetes in the average populations. You go from 13% to almost 27%. Not quite doubling, but getting there. Another thing to note is that there are racial differences amongst people with diabetes, from almost 12% in whites to 16% in blacks, 15% in Asians, and 14% or 15% in individuals who are of Hispanic origin. And going from this to pre-diabetes, you can see that among the group of people over the age of 65, the rate of pre-diabetes is almost 47%, and somewhat higher than the younger group, 45 to 64%. And if you add this to the 26%, you're pushing about 70% of people who either have pre-diabetes or diabetes in the older age population. And interestingly, only 22% of these people, or 1 in 5, are actually aware of their pre-diabetes situation. The question, of course, is how do we change all that? Now, what are the A1Cs of the population over the age of 65? If you look at the A1C less than 6.5, which is where we all should be, it's about 37%. Between 6.5 and 8, it's about 17 and 25% respectively. And over the in A1C over 8 and less than 10, or greater than 10, but between 8 and 10 is about 20%. So 20% of the people are in the range that we really should be working on improving their outcomes, especially those people who have very high A1Cs, because they become symptomatic, they lose weight, they get polyuric and dehydrated, they fall, they break a hip. And in this population, that's a very serious event. And so we'd like to see how could we optimize their glucoses while not causing harm. We all know from many years ago now that in type 1 and type 2 diabetes, if you improve their A1Cs, they have better outcomes in terms of their microvascular complications. In type 1 diabetes and in new onset type 2s, you can have very dramatic changes, going from an A1C of 9 to 7, and these are in the 70% range. But when you move it down a little bit and you go from the 8 to 7% range in new onset type 2s, you can see that the effect is much less. If you go to very established diabetes, should I start my video?
If you're able to.
Do you see any slides?
No, we see the slides. I think there was a request from the audience to see Dr. Banerjee herself.
Aha. Okay, I think I'm going to hold on that one.
Okay.
So if you have very severe type 2 diabetes, the benefit is somewhat less when you go, say, from an A1C of 7 to 6, and there might even be harm. Now the slides aren't moving. Any thoughts, Michael?
Are they moving on your screen?
No.
Did you? I mean, it doesn't seem that your computer froze, because we can still hear you. Did you maybe try to turn the sharing off and share again?
Okay, thank you. Let's see.
All right, we're back on your slide.
Oh, here we go. Here's the next slide. So this slide really looks at, is there any adverse effect of a higher hemoglobin A1C in older adults with and without diabetes? So this is again NHANES data that looks at the distribution of normal A1Cs with some bleed into the higher range, and the population distribution and the hazard ratio of cardiovascular disease. And you can see that as the A1Cs gradually rise, the likelihood and hazard ratio of coronary heart disease also rises. And the next slide is a little easier to follow in the sense that if you just look at the top line on all-cause mortality, on the far right is diagnosed diabetes. And the relative hazard ratios, if you have diagnosed diabetes with an A1C less than 6.5, is 1.3, going up in the next category of A1C from 6.5 to 7 to 1.6. 7 to 7.9 A1C is also 1.6 hazard ratio. And then 8 to 8.9 is 2.2, and greater than 9 is 2.6. You can see that they're different. I'm not going to go through the rest of all of these options because the all-cause mortality is a conglomerate of cardiovascular mortality, cancer mortality, and non-cardiovascular mortality. They're all a little bit different, but the bottom line is it gradually goes up, but it really increases above the A1C of 8 and above 9. Undiagnosed diabetes with an A1C greater than 6.5 also has a hazard ratio of 1.3 compared to somebody with no diabetes and an A1C less than 6.5. So that, yes, it does make a difference in terms of overall mortality. Some of the comorbidities that individuals with diabetes have in the older age group is cognitive dysfunction. In one study called the ACCORD study, which we had done here, was a very large study. 20% had baseline cognitive dysfunction, even though we tried to select them out for completely normal cognitive function. Functional impairment is also an issue with much less physical activity. About 50 to 70% of people who are older have peripheral neuropathies, which decreases your balance. and worse, makes you much more unstable, resulting in falls and muscle atrophy. Again, things that are difficult to deal with and are less of a problem in younger people. Polypharmacy is another problem in people who are older with diabetes, and greater than 6 medications per day increases the likelihood of falls. Vision loss is present in 20% of patients with diabetes, and hearing loss is twofold higher with diabetes in people who are older. So not only do you have diabetes, but you have a lot of difficulty in managing your diabetes. And I know from going to diabetes clinic, we often increase the number of medications and the complexity of the regimen that we provide for patients without really thinking about, are they going to be able to take it, let alone afford it or want to take it? Another aspect of diabetes includes depression. And I know in primary care clinics nowadays, everybody gets screened for depression. So those of you in psychiatry should know that we often send you patients. And this is something that I found recently, which I thought was interesting, because we are seeing, this describes basically a forest plot with A and B at the top and the bottom. The forest plot of the section A is really taking patients with baseline depression and asking, what is the incidence of diabetes that develops over time? So if you have a depressed population, you have an odds ratio of this developing in multiple studies of about 1.6. On the other hand, if you have a baseline diabetes population, the incidence of diabetes appears to be 1.5. So it's a little bit different. So I often wondered across the street where I'm at diabetes clinic, why is it that we don't see that many people with depression in our population? Is it because they don't answer the questionnaire properly? We don't ask the questions properly, but perhaps it's because that within the baseline diabetes population is less depression than diabetes is within the greater depressed population that one might otherwise see. So I'll ask you if you have any comments on that one later. Now, what's the pathophysiology of diabetes, and is it any different in people who are older? So this slide basically shows you some of the metabolic abnormalities in type 2 diabetes, and these are just a few. There must be many more because we have not figured it out yet. And you can see that part of what creates hyperglycemia, which is in the center of the slide, is an influx of glucose from the intestines. Another aspect of what creates hyperglycemia is an excessive glucagon secretion, which is one of the counter-regulatory hormones. There's also a decrease in insulin secretion from the pancreas. There are problems with the central nervous system. It doesn't recognize excessive food intake. There are probably neurotransmitters that are not working quite right. There's also peripheral insulin resistance that you've all heard about, with decreased peripheral glucose uptake in both muscle and fat cells. Some newer aspects of diabetes physiology includes something called the renal glucose excretion, in the sense that we reabsorb 90% of the glucose that we excrete through the proximal kidney tubules, and we reabsorb too much of it if we have diabetes. And finally, there is an excess of liver glucose output in type 2 diabetes. And the question, of course, is what are the signals that regulate all these things, and can we modify them in any way? We have medications for probably all of these things. And what that means, but I don't think we have ever figured out what the true mechanism is. Maybe it's a mitochondrial problem, and that the mitochondria are either not working very well or are not functioning, but we don't address the mitochondria directly. So what happens is we try and address any one of these pathophysiologic mechanisms, and another one simply pops up and takes over. And regardless of what we do, the glucoses often seem to go up. When we ask individuals to decrease their food intake and glucose intake, it's very difficult to do, as all of us know. And we can override almost any medication that we can give a patient by excess eating. So I'm going to only focus on some of the studies that have been done specifically in the elderly to address one of the key aspects of physiology here, which is decreased insulin secretion. Because what can happen is you can have a great deal of insulin resistance or increased hepatic glucose output, and most people who don't have a deficiency in their beta cells can progressively increase insulin secretion and maintain normal blood sugars. So here's a study that was done in people who were young with normal diabetes, old with normal glucose tolerance, and old with impaired glucose tolerance. And they did this by infusing intravenous glucose into these patients. And you can see on the top graph that all the glucoses over the 220-minute time period are essentially the same. Maybe there's a little bit of difference between the blue and the black dots and squares. But essentially, there's no difference. If you go down to this lower panel, which is measuring insulin secretory rate, you can see that even though these panels at the top were normal and glucose is the main stimulus for insulin secretion, that young people who had normal glucose tolerance had the highest insulin secretory rate, followed by older people with normal glucose tolerance, and the lowest insulin secretory rate was found with people who had impaired glucose tolerance and who were old. And this has been replicated many times and really gives us a sense that failing beta cell function and failing insulin secretion is probably the key thing that distinguishes someone with a high glucose from someone with a normal glucose, even if they have a lot of other metabolic abnormalities at the same time. So to put this in a big picture, if you have diabetes on the far right and aging on the far left, you can see that aging directly decreases beta cell function and leads to diabetes, but it's also aided and abetted by the effect of aging on many indirect factors, such as genetic risk and background, lifestyle changes. It decreases physical activity. There's increased obesity with aging. There are other comorbidities and other inflammatory functions that occur with aging. And this also directly affects beta cell function, and it also promotes insulin resistance in the periphery at the liver and muscle. Again, these things stress, if you have insulin resistance, you have stressed beta cells because they have to produce more insulin. And all these things together and separately lead to type 2 diabetes and hyperglycemia. So one of a few questions are, can we prevent diabetes, and can we prevent diabetes in older people? And the second question is, can we prevent the complications of diabetes? So there are two approaches to this. We can prevent the complications of diabetes by preventing diabetes in the first place and not having it. Or we can prevent the complications of diabetes by somehow, once you have diabetes, either modifying the glucoses, the blood pressure, the lipids, to prevent the development of the various complications of diabetes that are so familiar to everyone, both microvascular disease and cardiovascular disease. So there was a study called the Diabetes Prevention Trial quite a few years ago, which took about 3,000 people of diverse ages, races, and ethnicities, and asked, did lifestyle make a difference? Did a metformin intervention make a difference compared to placebo? The lifestyle participants had about 150 minutes of exercise a week of moderate intensity. And if they were obese or overweight, they were placed on a diet, which included meal replacements. And we used to say when the study was going on is basically you were assigned a chef and a trainer. And with that, people could actually accomplish some amount of weight reduction and increased physical activity on a long-term basis. 20% of the participants were over the age of 60 years old, and this is ranges between 60 and 85 years. The duration of this study was interesting because it was stopped early because of its very positive outcomes. And on this slide, you can see that there were changes in body weight and leisure physical activity. The body weight is on the first panel. It goes down with lifestyle. Leisure time physical activity went up with lifestyle, but not metformin or placebo. And medication adherence was what it was, about 70%, and tracked with the placebo degree of medication adherence. The results are on the next slide. And the incidence of diabetes was lowest with lifestyle. So you can see lifestyle did best. The incident development of diabetes was about 20-some%. Metformin was next best, and placebo was the control. And you can see that lifestyle gave you a 58% decrease in the development of diabetes. And metformin worked, but it wasn't so good. And if you drill down a little bit, there were some interesting differences in the subpopulations. So I've circled this because we're interested in older people. It turns out that lifestyle worked best in older people. There was a 71% reduction in diabetes versus in younger people, there was a 48% reduction. Comparing metformin to placebo, metformin didn't work very well in older people who incidentally turned out to be thinner than the younger people. And it worked much better in people who were 25 to 44 years old. And if you look down at the body mass index at the level of degree of the BMI, you can see that lifestyle worked reasonably well in all three categories, but metformin did not work so well in younger people who were thin, but worked much better in older people who were overweight. So these are some of the little issues that we've come to understand, that lifestyle is probably the most potent thing that one can do to change the development of diabetes. Again, of course, it's the most difficult to do. Now, how did this work? It turns out that in patients who were on metformin, their fasting glucose was nice and low, just compared with the A1C, compared with metformin. You can see the fasting glucose went down over the course of the study, and the glycosylated hemoglobin, however, went down better with lifestyle than it did with metformin. And the reasons are on the next two slides. If you look at the fasting plasma glucose, they are equally looking for normal fasting glucoses were the same in lifestyle and metformin and compared to placebo, which didn't do as well. And it did so over the course of the years. The fasting plasma glucose normality goes down, but they're basically matched. If you ask what happens after a meal, you can see if you just look at year one over here in the middle, that only the people on metformin had a higher degree of normal plasma glucose after a glucose load. It turned out that after a meal, neither metformin nor placebo did very well in normalizing the glucose. So naturally, if you ask in which groups were the fasting and the post-load glucoses best, they were obviously only best in the individuals who were in the lifestyle intervention group. Now, there's another study that looks at weight loss by itself, and that showed that it didn't achieve benefits of mortality in any age group. However, there were significantly greater secondary benefits of improved physical function and fitness in older people, which was greater than younger participants. There were decreases in weight and A1C and urinary incontinence and depression and a whole host of things that had more to do with lifestyle, with the patients being happy with the way they were rather than they're living any longer. The NIH thought this was a study that didn't do very well because there was no benefit for mortality in 13 years. But the patients were very happy because they felt better and they were much fitter and did well. So moving on to treatment of patients with diabetes, one needs to have a very comprehensive view of this because diabetes, since it has to do with sugar, and sugar is our basic fuel, regardless of what we eat, one has to have a very comprehensive approach to this. So there's not only glucose regulation, but the lipids have to be appropriate. Blood pressure needs to be controlled. For the most part, one needs to have an antiplatelet agent and to stop smoking. So we often think of this as the ABCs of diabetes treatment. And let's see how this works. But issues specific to older adults include avoiding symptoms of diabetes, of polyuria and polydipsia and weight loss. It involves minimizing the risk of acute and chronic diabetes complications and optimizing health-related quality of life. And this is only a very short list. And the targets of treatment require a balance of benefit versus harm. And this is true for all patients all the time, but it's particularly true of older people where it's easy to cause harm and certainly inadvertently, especially inadvertently. So for example, if one is being treated for lipids with a statin, which is almost standard of practice for almost all patients, this may result in myalgias in the elderly and cause problems with them. They may not realize why it's happening, and their provider also may not think of it. If one is treating blood pressure, and if one goes for a very intensive blood pressure control, it may cause hypotension and may cause falls, and particularly postural hypotension, and falls again have a ream of ramifications that follow from that. Strict glucose control can cause hypoglycemia. Hypoglycemia can be associated with death. And the cause of the hypoglycemia death connection is really because of the association of arrhythmias that happen at very low glucoses. And finally, antiplatelet medications have a higher risk of bleeding. Now, one of the problems with trying to use the large evidence-based studies that are generated is that to modify one's cardiovascular risk or whatever risk you're looking for, is that no trial assesses whether older adults with diabetes benefit from these atherosclerotic cardiovascular risk factor modification trials. They're all in a much younger group. Some of them have small numbers of people who are older, and that comes as part of the subset analysis, subgroup analyses. But there's very few studies that are really focused on this population. So that benefits for the older population are inferred from studies of younger populations. And as everybody knows, when you enter a patient into a randomized control trial, they tend to be healthier and less complicated than those people that one might see in clinical practice. So, and the focus of these studies of the younger populations are really only largely focused on mortality, specifically cardiovascular mortality, and not quality of life or functional capacity, which is what somebody who's much older might actually be interested in. What about some factors that might contribute to the health of older people with diabetes? And I think these are something that all of you are very familiar with. For example, can your patient use the phone? Can they use a computer? Many of my patients can't or don't have one. Can they shop? Can they do housework, laundry, make meals, drive, take their meds, their multiple meds at multiple times, which truly seems like a huge burden for them? Can they manage their money? And as I look at this and I think of myself in clinic, I say, I never really think about these very carefully, and we should be. There are also numerous comorbidities that patients have, and for each of these comorbidities that you can see between arthritis and cancer and heart failure and kidney disease and depression, each subspecialist adds yet another combination of medications to their regimen and refers them to another subspecialist. So they, I think, really should be treated in one place where somebody can put all this together and perhaps minimize the number of medications that they take. So in assessing and treating patients, one needs to think of their cardiovascular disease and heart failure risk, cardiovascular risk factors, their 10-year risk, chronic kidney disease, and especially their hypoglycemia risk. And then to set some targets that are reasonable and sensible in conjunction with the patient, an A1C, what's the blood glucose target, what's the blood pressure target, and what are your self-management goals? And I'll leave and the treatment plans follow what your assessments really are. Now, one of the a main finding that came out of the ACCORD study, which was now, I'd say, 15 years old, was that very intensive glucose control didn't save lives. In fact, if you tried to intensify glucose control to an A1C of less than 6, you actually had an increase in mortality. So there was a great deal of disappointment with that study. But what came out of it, which no one had anticipated, was something that looks like this. And that is that that one size doesn't fit all, and that there were patient and disease factors that actually determined outcomes that needed to be considered. So that sometimes you needed an A1C that was more stringent, which is on the left-hand side of these sideways triangles. And other times you needed an A1C that was less stringent, to more and less stringent. Some of these things are not modifiable, such as how long you've had your diabetes, or what other risks you have of hypoglycemia or life expectancy or other comorbidities or established vascular complications. And in that case, if you happen to fall in any of these categories here, then the A1C goal should be less stringent. On the other hand, if you don't have any of these complications, if you're newly diagnosed, for example, if you're young and expect to live a long time and are hoping to prevent the complications, then maybe you do want a very stringent A1C level. And finally, something that we often fail to consider are things like patient preference and their resources and their support system, which are absolutely incredibly important. And that is, does the patient really want to do this? We often think that if we educate them, they're going to come around to thinking this way, but sometimes they actually don't. And these are potentially modifiable if the person prefers a less burdensome therapy or has very limited resources and a support system. Then maybe the A1C should be loosened up and be less stringent. But if these things are all available and the patient is motivated and can do things, then they should be, the A1C should be optimized, because it's very difficult to get an A1C to less than 7. And so this is something that came out, and these are some of the considerations as we look at older people to create a framework for how to approach what kind of treatment they should get. Another aspect is we have to assess their hypoglycemic risk and what are some of the things that increase this risk. One of them is the use of insulin and insulin secretagogues, such as sulfonylureas, glipizide, glyburide. Others are impaired kidney function, a long duration of diabetes, frailty in older age, cognitive impairment. One can have impaired counter-regulation, such that if the glucose goes down, there's no way to bring it back up, in that glucagon may be not there, catecholamines may not respond properly. And then there may be physical and mental disabilities that impair the response to hypoglycemia. And with aging, one's responses decrease. There may be polypharmacy, there might be alcohol use, and all of these may come together to increase one's risk of hypoglycemia. And hypoglycemia is one of the main things we just don't want to do, regardless of what's going on. Now, in the past, I would say since the 50s, we've had an incredible increase in the number of pharmacologic agents that we can use to take care of patients with diabetes. And every time we have a new drug, we think this is our savior, our A1Cs will be normalized, and patients will live forever. And so there's great enthusiasm with the new drug. And the question is, as time goes by, we discover that isn't always the case. But some of the things you might know well are such things as metformin, thiazolidinediones, short-acting sulfonylureas. Sulfonylureas actually came around much later. And of course, insulin has been there since the 1920s. And I showed you this picture of the metabolic abnormalities and the drugs that go with them. And so many people have thought that rather than just have an older person as a monolithic entity, one needs to consider that not all that there's a lot of diversity amongst the old age group. Some are extremely healthy. They have very few chronic illnesses. They have intact cognitive and functional status and a long remaining life expectancy. In these people, it might be reasonable to have an A1C goal of less than 7.5 and not less than 7. And what does that translate into fasting glucoses? 90 to 130, a bedtime glucose of 90 to 150, and a blood pressure of less than 140 over 80. And the need for lipid lowering, a statin, unless it's contraindicated or it's not tolerated. And if it's not tolerated, I wouldn't push the patients into this, because if they're doing well, I would say let's let them do well without driving them crazy. If, on the other hand, they are complex with intermediate and an intermediate type of health status with several coexisting chronic illnesses, or two or more instrumental activities of daily living impairments or mild to moderate cognitive impairments, we should, and with an intermediate life expectancy and a high treatment burden with hypoglycemia vulnerability, we should loosen up our A1C considerations to an A1C goal of 8% so we don't have problems with hypoglycemia and falling. And this translates into a glucose of, say, 90 to 150 fasting, a bedtime glucose of 100 to 180, same blood pressure, and again, statins unless contraindicated or not tolerated. On the other hand, we have a lot of patients who have a very poor health. They have end-stage chronic illnesses, moderate to severe cognitive impairment, and problems with activities of daily living. And their limited life expectancy makes a benefit uncertain. These patients I would keep at an A1C of less than 8.5, perhaps less than 9, so long as they're asymptomatic. And the fasting glucose could be up to 180, the bedtime glucose up to 200, the blood pressure somewhat higher. There is no head-to-head evidence-based medicine as to whether these things are valid or not, but these have come more out of people coming together and creating guidelines, not even guidelines, but considerations, because there are no guidelines for things like this, as to what is the most sensible way to deal with people who are older, to keep them comfortable and to have optimized their life expectancy and their lack of complications during their life that they have. Now, there are some cardiovascular outcome studies that have had small enough patients groups, and I just want to point out two of them that are fairly recent. The one on the top and the bottom are quite old, and that approach is not used. But with empagliflozin, which is an SGLT2 inhibitor, studied a population of type 2 patients with cardiovascular disease with a mean age of 63. And they looked for cardiovascular death or non-fatal MI and stroke at about 3.8 years. What they found was that empagliflozin versus placebo had a benefit. Placebo had decreased the complications by 10%, the study drug empagliflozin by 12%, and there was a significant benefit in subjects who were above the age of 65, but not below the age of 65 for primary outcome. So we're not exactly sure what this means, and no one ever thinks about it, no one ever discusses it in public, because the majority of patients were under the age of 65, but this drug is promulgated, and this whole class of drugs are promulgated for people under the age of 65. And we worry when we use them in older people because of side effects. Another class of drugs are the GLP-1 receptor agonists, and here's an example called liraglutide. Again, a similar patient population, again, a benefit with liraglutide, and this time significant benefits in patients less than the age of 60, but not in people above the age of 60. So the question is, what do we do about things like this? So that the evidence in the older population is not as good as we would like it to be. Some of the drugs that we use are listed here. There are about 6 or 7 of these, and I'll go through these briefly for house staff who may actually be treating patients. One of these are the sulfonylureas, glipizide and glyburide. The issues with the elderly population is hypoglycemia, especially with glyburide. They need to be adjusted for renal insufficiency, and they are low cost. And they're probably among the largest worldwide drugs used anywhere in the world because of their low cost and long duration of their own lifetime. They've been around for a long time. Glynides are a very short-acting version of a sulfonylurea. They cause hypoglycemia also, but you can take each one with a separate meal so that you don't you can tailor the elderly person who only wants to eat 1 or 2 meals. And I often use these in people who are older, who need just a little bit of extra insulin, because these are insulin secretagogues. The cost is moderate, and they again need to be adjusted for renal insufficiency. Biguanides are metformins, which are universally used in people, cannot use them in patients with GFRs less than 30, not 45. Lactic acidosis is rare, but they do have GI side effects with some nausea and diarrhea, which over time will dissipate, but in the beginning is hard for patients to tolerate. So among the elderly, they often can't tolerate because of nausea and diarrhea, and sometimes they lose weight with this drug, and sometimes the older person is having trouble maintaining body weight. So this can be somewhat of a problem with older age people. I'm going to skip the next drug. DPP-4s are sitagliptin, saxagliptin, this class of drug. They increase one's GLP-1, and GLP-1 is a hormone that we make when we eat, and it helps with satiety, it helps with insulin secretion, and several other issues. But there's a very low risk of hypoglycemia with it because these drugs, as the insulin goes up, as the glucose comes down, the insulin also comes down that's made by the body in response to these drugs. So they don't have much hypoglycemia when used alone, so they're easy to use in that sense. There's some reports of pancreatitis, some musculoskeletal problems that I've seen, and sometimes there's an increase in urinary tract infections. They're also very expensive. The GLP-1 receptor agonists are injectable drugs. These give you a pharmacologic dose of GLP-1, whereas the DPP-4s on the upper, in the line above, give you a physiologic increase in GLP-1. And these actually actively very much work to decrease blood sugars. They have a very low risk of hypoglycemia because the GLP-1 is in sync with the the insulin releasing occurs in sync with the changes in blood sugar. They also have nausea and vomiting and anorexia, sometimes pancreatitis. And one benefit, if your patient is obese, is that patients can actually lose weight. And finally, there are SGLT2 inhibitors, which are the empagliflozin, dapagliflozin, and canagliflozin types. And these are interesting in the sense that you lose glucose through the urine. So if you have a high blood blood glucose, you can pee out the excess sugar. And along with this benefit comes dehydration, because if you have to excrete sugar through the kidney, you have to excrete water with it. So that it can be dilute enough. And this leads to increased genital infections and urinary tract infections, and sometimes can cause a kind of diabetic ketoacidosis that is associated with a normal blood sugar, which is interesting, but not good for patients. It's very rare, but nevertheless, these things occur. So with some good, you have to get some bad. Again, you adjust the dose for renal insufficiency. Again, these are very expensive. They range anywhere from $600 to $1,000 a month, and so we don't use them very often in our practice. This slide looks at some of the important things, such as nutrition, the lifestyle issues, physical activity of walking, sleeping at night, behavioral support, and smoking cessation. And without these aspects, we could never get our patients to do well at all. So these are extremely important. Now, I mentioned hypoglycemia risk. And one of the commonest drugs that we actually use among our older diabetes patients, because there are fewer side effects, is an insulin regimen. And so what we do is we often de-intensify and simplify the insulin regimen. So if patients are on basal insulin, we change them from bedtime to morning, because it's easier for patients to do things in the morning rather than bedtime. If there's a mealtime insulin, we try and decrease the dose a little if necessary. And if they're on pre-mixed insulin, we might actually use 70% of the total dose in the morning. And often we use a pre-mixed insulin because to minimize the number of injections that a patient actually has to have. So there's a lot of granularity on this slide, which is useful if you're actually sitting in front of the patient, but otherwise I'm not going to go over it. But it's here, and it's in this year's standard of practice. And what I should tell everybody is that the American Diabetes Association annually in January puts out a standard of practice for diabetes management that sort of reviews all the sorts of things on a very granular clinical basis that people should be doing, and the evidence behind it. So it's a very good resource. It's an annual thing, and this comes from the 2021 edition. I think we have a few more minutes. Do I have any time, Dr. Reinhardt?
Yeah, we have a couple more minutes before we
okay. So one
break
of the
for the
things,
next section.
Yeah, one of the things that I'm going to just mention and not go into any data then is that these GLP-1 receptor agonists that I mentioned earlier, and SGLT2 inhibitors, are interesting in the sense that they decrease cardiovascular complications. And the SGLT2 inhibitors are very interesting above and beyond that because they work in people with diabetes and without diabetes, which was a complete surprise when this actually happened. I'm going to skip through this. These are the actions of GLP-1 receptor agonists. And just go through the GLP-1 receptor agonists and their effect on major cardiovascular endpoints and cardiovascular mortality. And you can see that all three of these, three different drugs, all have a similar effect on decreasing primary major cardiovascular endpoints. And so we think that this is a class effect and a very good benefit for patients. In terms of SGLT2 inhibitors, they decrease the reabsorption of glucose in the proximal convoluted tubule. And again, what was fascinating about this group is they decrease major cardiovascular outcomes and death. They do it very early, and particularly they decrease the rate of hospitalization for heart failure. And all the drugs that have been studied to date have decreased the rate of heart failure. Almost none of them have decreased the death from heart failure, but they have decreased overall cardiovascular mortality. And I think that, and you can see that there are three different major trials over here, 1, 2, and 3, and heart failure hospitalizations are down very profoundly in all the groups, as well as major cardiovascular endpoints. And I think that since we only have another minute or two, just some complications, because these are maybe much more common nowadays to use. There's the GLP-1 receptor agonists cause nausea, vomiting, diarrhea sometimes. So to minimize this, we start low and go slow. For the SGLT2 inhibitors, sometimes people get DKA, urogenital infections, falls, dizziness, Fournier's gangrene, amputations in one group but not in any others, some bone loss, this was controversial, and possibly an increase in LDL cholesterol, although mortality is decreased in all of them. So I think that I'm going to stop here and just summarize that diabetes is very common amongst olders. Management should be individualized, especially the intensity of glucose lowering efforts. And it's important to consider de-intensifying glycemic control if it's warranted. And I think that's about all I have to say now. So thank you all for listening.